into it. Today, we're diving deep into sedatives and hypnotics.
Yeah, a really crucial area.
Definitely. Whether you're thinking about helping someone with sleep, managing anxiety, or just understanding the meds used in procedures, it's pretty fundamental stuff.
Exactly. And what we want to do here, really, is give you a clear breakdown. The different classes, how they work, their uses, and critically, the safety side of things.
Think of it as a focused guide.
Right.
And for you listening, especially those of you using this maybe as a voiceover for the KMR Advise YouTube channel materials, our goal is a solid, understandable overview. We'll hit the classifications, the mechanisms, how they actually work in the body, and the really key clinical points you need as you're learning.
Sounds good.
Okay, so let's start big picture. How are these actually used day to day in the clinic?
Well, the material lays out several key areas. One big one is insomnia, right? Short-term management.
Difficulty falling asleep, staying asleep.
Exactly that. And in those cases, you might see drugs like zolpidem or isopuclone being used.
Right. Okay, but it's not just sleep, is it? Anxiety is another major one.
Oh, absolutely. Things like generalized anxiety, panic attacks. These are conditions where benzodiazepines, maybe like alprazolam, can be really helpful.
Okay.
Then there's procedural sedation.
Ah, like for endoscopies, maybe dental work?
Precisely. For those, you often want something shorter acting, like midazolam. Helps patients relax, stay comfortable during the procedure itself.
It's interesting how broad the applications are. The notes also bring up seizure control, particularly acute seizures, mentioning lorazepam. Why? Why sedatives there?
Well, many sedatives, especially the benzos and barbiturates, they work by boosting GABA inhibition in the brain.
Okay, GABA, inhibitory.
Right, and that helps dampen down that excessive neuronal firing that causes seizures. Lorazepam's pretty quick acting, so it's good for those acute situations.
That makes sense. And the last one mentioned is alcohol withdrawal. Using drugs like diazepam to prevent complications, like DTs, how does that work?
So alcohol withdrawal can cause this state of neuronal hyperexcitability. Benzodiazepines, again, by enhancing GABA's calming effect, help counteract that excitability.
Preventing those severe symptoms.
Exactly. So you can see a really diverse range of uses. Now, maybe we should look at how these different meds are grouped together.
Yeah, the classification. So the source divides them into main classes, and it's quite practical. It even lists some common Indian brand names. First up, benzodiazepines.
The classics.
Right, like diazepam, lorazepam. You might see them as Valium, Compose, or Ativan.
Then you've got the non-benzodiazepine hypnotics, often called the Z drugs.
Like zolpidem, isopuclone, known as Zolfresh, Zolpi, Isopra, perhaps.
Exactly. And it's worth remembering, while they act similarly to benzos in some ways, they are a distinct class.
Okay. Then barbiturates. Phenobarbital is the main example here.
Luminal, Gardinal might be the brand name.
And the note here is these have a narrower safety margin, right, compared to newer drugs.
Generally, yes, they require more caution. Then we have melatonin receptor agonists, Ramelteon specifically.
Marketed as Rosarum. And these work differently.
Completely different mechanism, yeah. They target the body's natural sleep-wake cycle regulation.
Interesting. And lastly, antihistamines, like diphenhydramine Benadryl, maybe Diuter.
That's the one. And the key thing here, as the notes point out, is that using these for sleep is usually off-label. It's leveraging that sedative side effect they have.
Gotcha, off-label use.
And even within these big categories, there are important differences. Take diazepam, a bendo long half-life.
So it sticks around longer. Good for sustained anxiety relief, maybe.
Right, or seizure control.
Yeah.
But yeah, it stays in the system. Compare that to midazolam, another benzo, but very short-acting.
Making it better for those procedures we talked about. Quick on, quick off.
Exactly. Much more suitable.
And what about the non-benzos, like zolpidem? The notes mention its selectivity for the GABA alpha-1 subunit. What's the significance of that?
Ah, yeah, that's interesting. The idea is that this selectivity might be why zolpidem tends to cause less muscle relaxation compared to the broader-acting benzodiazepines.
Because benzos hit more GABA-A subtypes.
That's the thinking. So potentially an advantage if you need sedation but want to minimize muscle weakness?
That's a really useful distinction. Okay, and barbiturates, again, phenobarbital, effective anticonvulsant, but this high risk of respiratory depression and overdose. Why is that such a concern with this class?
Well, compared to benzos, barbiturates have a less predictable dose-response curve. They can cause really profound CNS depression, including breathing, even at doses not far above the therapeutic range.
So much less forgiving, requires very careful dosing and monitoring.
Absolutely essential. Okay, so we've got the categories down. Should we dig into how they actually work, the mechanisms of action?
Yeah, let's do that. So for the benzodiazepines and the non-benzos, the Z drugs, the mechanism is quite similar, right? Both involve the GABA system,
Correct. They both bind to specific sites on the GABA A receptor complex.
which is on the nerve cells.
Right. And the key thing is, this binding doesn't activate the receptor directly, but it makes the receptor more sensitive to GABA itself.
GABA being the main inhibitory neurotransmitter, the brain's brake.
You got it. So when GABA then binds, because the receptor is enhanced by the drug, it allows more chloride ions to flow into the neuron.
Okay, chloride ions, negative charge.
Exactly. More negative charge inside means the neuron becomes hyperpolarized,
Right.
less likely to fire an action potential.
Ah, so making neurons less excitable, that's how you get the sedation and the anti-anxiety effects.
Precisely.
Well,
Now, barbiturates also target the GABA A receptor, but slightly differently.
how so?
While benzos and Z drugs increase the frequency of the chloride channel opening when GABA binds, barbiturates increase the duration the channel stays open.
Ah, so they keep the brake pressed down longer for each GABA molecule?
Kind of, yeah. They prolong that inhibitory effect, and that helps explain why they can cause deeper CNS depression and have that higher overdose risk we mentioned.
Makes sense. Okay, then the melatonin agonists, like Ramultine. Totally different pathway.
Totally different. They activate melatonin receptors. MTO and MTRO located in the suprachiasmatic nucleus, the SCN.
The SCN, that's the body's master clock, right? Regulates sleep-wake cycles.
That's the one. So by hitting these receptors, Ramultine essentially mimics melatonin's natural signal, helping to promote sleep onset.
More aligned with the body's natural rhythm.
But you could say that.
Yeah.
And finally, the antihistamines, like diphenhydramine. Sedation comes from blocking ACHR receptors. What's histamine got to do with being awake?
Histamine in the brain is actually a key player in promoting wakefulness and alertness.
Ah, okay.
So, by blocking its ACHR receptors, these antihistamines reduce that wakefulness signal, leading to drowsiness. But again, it's a side effect being used off-label for sleep. Understood. Wow, okay, so understanding these different mechanisms really clarifies why the effects and safety profiles vary so much. Speaking of safety, the source mentions why these are generally safe when used properly.
Yeah, and it highlights a key safety feature of benzodiazepines compared to barbiturates, the ceiling effect on respiratory depression.
Meaning, unlike barbiturates with benzos, increasing the dose beyond a certain point doesn't proportionally worsen the breathing suppression.
Essentially, yes.
Yep.
It plateaus to some extent, which makes them relatively safer in overdoses compared to barbiturates, which lack that ceiling.
That's a crucial safety point. And for the Z drugs, their more selective receptor binding is thought to lead to fewer side effects.
Right, fewer of the broader side effects you might see with less selective drugs, like maybe less muscle relaxation or cognitive impairment, although they certainly still have side effects.
Okay. But even with these relative safety profiles, tolerance is an issue with chronic use, especially for the GABA drugs.
Definitely. The notes explain this as downregulation of GABA A receptors.
Right. What does that mean practically for a patient? Downregulation.
It means that over time, with the drug constantly present, the brain adapts. It actually reduces the number of these GABA A receptors on the surface of the neurons.
So the brain becomes less sensitive to the drug.
Exactly. The same dose has less effect than it did initially. So the patient might need a higher dose to get the same sedative or anti-anxiety effect. That's tolerance developing.
Which is a major clinical challenge and can lead towards dependence, too.
Absolutely. It's a slippery slope.
Okay, let's pivot slightly to pharmacokinetics, how the body handles these drugs. The source has a helpful table.
It does. It outlines onset, metabolism, excretion. Let's take diazepam again.
Yeah.
Oral onset. About 30 to 60 minutes.
Okay.
Metabolism is mainly hepatic, liver, using those cytochrome P450 enzymes, specifically CYP3A4 and 2C19.
Breaking it down.
Right, breaking it down into metabolites, which are then made more water-soluble through glucuronidation and then excreted mostly by the kidneys.
Got it. And zolpidem, quicker onset, 15-30 minutes, also liver metabolism via CYP3A4.
Correct. And its metabolites are inactive, then cleared by the kidneys.
Phenobarbital, similar onset to diazepam, 30-60 minutes orally. Different enzyme, though, CYP2C9.
Yes, primarily 2C9. And interestingly, some phenobarbital gets excreted unchanged by the kidneys, which can be relevant for interactions.
And Ramultine, about 30 minutes onset, big liver metabolism, mainly CYP1A2, inactive metabolites, kidney excretion.
That's the summary. So understanding these profiles helps predict how fast they work, how long they last.
And potential drug interactions based on those CYP enzymes.
Exactly. The source also pulls out some really useful clinical pearls, practical takeaways.
Yeah, these are good. Like lorazepam having no active metabolites, why is that a big deal clinically?
Well, if a drug does have active metabolites, those metabolites can also have effects, and importantly, they can build up, especially in someone with, say, liver problems.
Because the liver isn't clearing them effectively.
Right. Since lorazepam doesn't have those active metabolites, it's often seen as a safer choice for patients with liver disease. Less risk of accumulation.
That's a really key point for patient selection. And zolpidem's short half-life, 2 to 3 hours, minimal next-day sedation, that seems like a clear advantage.
It often is.
Huh.
Shorter half-life means it's cleared faster, so less chance of feeling groggy or sedated the next morning, which is crucial for people needing to function.
Definitely. But of course, no medication is without potential downsides, adverse effects.
And the source lists several common ones: CNS, depression, drowsiness, confusion. Seems like a direct extension of how they work, right?
Yeah, enhancing that GABA inhibition just slows things down.
Exactly. Can lead to sedation, confusion, maybe worse in older patients or at higher doses. Management, usually reducing the dose, avoiding alcohol or other depressants.
Respiratory depression is another serious one, especially, as we keep saying, with barbiturate.
Very serious. High doses can suppress breathing significantly. Severe cases might even need ventilation support.
And then tolerance and dependence, which we touched on. Withdrawal symptoms can happen when stopping, like seizures or rebound insomnia.
Yes, because the brain has adapted to the drug.
Yeah.
Take the drug away suddenly, and that underlying hyperexcitability can bounce back, sometimes worse than before.
So gradual tapering is key.
Absolutely crucial to minimize withdrawal.
What about these paradoxical effects? Agitation, aggression, that seems counterintuitive for a sedative.
It does, but it happens sometimes. It's thought to be a kind of disinhibition effect in certain people, maybe those with underlying issues. The drug removes the usual brakes on behavior inappropriately.
So you'd need to switch meds in that case.
Usually, yes. And finally, barbiturate overdose. Really dangerous coma, low blood pressure.
Due to that profound CNS and cardiovascular depression, requires intensive care.
Definitely. A stark reminder about careful use.
Which brings us to contraindications when not to use these drugs.
Right. There are absolute ones, like a known allergy or hypersensitivity. And specifically for benzodiazepines, acute narrow-angle glaucoma is an absolute contraindication.
Why glaucoma?
They can potentially increase pressure inside the eye in that specific type of glaucoma.
Okay. And relative contraindications. Situations needing caution.
Severe liver problems, as we discussed, especially for drugs relying heavily on liver metabolism, lorazepam maybe being safer there, and, importantly, a history of substance abuse.
Because of the potential for misuse and dependence?
Exactly. High risk there.
Okay, what about drug interactions? This seems critical.
Hugely critical. The big one is combining them with other CNS depressants, alcohol, opioids.
Additive effects?
Worse than additive, often
Reflective.
synergistic, massively increases sedation, and the risk of respiratory arrest can be fatal. Needs strong warnings.
Absolutely. And interactions with metabolism, like CYP3A4 inhibitors, ketoconazole is mentioned.
Right. Inhibitors like ketoconazole slow down the breakdown of drugs like zolpidem, which uses CYP3A4. So zolpidem levels can rise, leading to excessive or prolonged sedation.
The opposite with barbiturates. They induce enzymes.
Yes, barbiturates can speed up CYP enzymes. This
Yeah.
means other drugs metabolized by those same enzymes get cleared faster, potentially becoming less effective.
Like warfarin or birth control pills.
Exactly. So you might need dose adjustments for those other meds if someone starts phenobarbital. Really important interaction to track.
The source highlights an exam tip too. Flumazenil reverses benzodiazepine overdose.
Yes, it's the specific antidote.
But giving it to a chronic benzo user can trigger seizures. Why is that?
Because in someone chronically using benzos, their brain relies on that constant GABA enhancement. Flumazenil suddenly blocks the benzo's effect, ripping away that inhibition. The underlying hyperexcitability is unmasked all at once, potentially causing seizures.
Wow. Okay. So antidote, yes, but use with extreme caution in chronic users.
Precisely. Very important nuance.
Okay, let's look at some specific doses and maybe a few more clinical pearls. Zolpidem, 5-10 milligrams at bedtime, max 10 milligram a day.
Standard dosing. Diazepam depends on use. Anxiety, maybe 210 milligram a PO or IV. Alcohol withdrawal, often starting around 5-10 milligrams.
Phenobarbital for seizures, 6,200 milligram day, but needs level monitoring.
Essential to monitor levels with phenobarbital to stay in the therapeutic window and avoid toxicity.
And there's a specific pediatric note. Avoid long-term benzos in kids due to dependence risk.
Yeah, a really important caution for that population given their developing systems.
Okay, the source then summarizes toxicity and management in a table format. Let's recap that. Benzo overdose.
Main risks:
Yeah.
coma, respiratory depression, antidote. Flumazenil,
Barbiturate overdose.
more severe. Hypotension, hypothermia, management, supportive care, maybe hemodialysis, alkalinized urine to help excretion, no specific antidote like flumazenil,
And Z-drug overdose.
usual less severe.
Yeah.
Ataxia, confusion, management is mainly supportive care.
Got it. The material also flags some black box warnings. Zolpidem.
Risk of complex sleep behaviors, things like sleep driving, sleep eating. Patients absolutely need to be warned about this.
Barbiturates.
High overdose mortality risk.
Yeah.
And should generally be avoided in patients with depression or suicidal thoughts.
Rameltian also has a caution note for depression.
Yes, caution advised as it might potentially worsen symptoms or increase suicidal thinking in some patients with depression.
Right.
Needs monitoring.
And then a high-yield fact. Z drugs generally have a lower risk of tolerance compared to benzodiazepines.
That's considered a key advantage, potentially influencing choice for longer-term use, though long-term use of any hypnotic is generally discouraged.
Right. Okay, finally, there's a final exam checklist, a good summary.
Yeah, really distills the key points. It stresses knowing the MOA's GABA enhancement for benzo Z drugs versus melatonin agonism for Rameltian.
Reminds us about flumazenil for benzos, and importantly, no antidote for barbiturates.
Highlights overdose signs, respiratory depression being worse with barbiturates.
And the need to monitor breathing, kidney, and liver function.
And flags midazolam again is key for procedural sedation, rapid onset, short action.
Okay, well, I think that covers the core material pretty thoroughly.
Yeah, we've gone through quite a bit there. Uses, types, how they work, safety, clinical pearls. Hopefully that gives you, our listeners, a really solid foundation on sedatives and hypnotics.